Hi guys, give me a thumbs up if I'm visible to you and audible to you. So welcome to MedEd's Farre. I know most of the universities have the professional exams just around the corner and all of you are seriously preparing for it and definitely you're going through anxiety. And Farre is MedEd's way of helping you guys deal with your prof exam. Now let me begin with a disclaimer because generally when I try to teach some topic for YouTube, I try to focus more on the concepts because concepts are the ones which stay long in our mind and that's what we apply when we diagnose or treat a disease. But when it comes to Farre, I'm not going to get into the concepts because Farre is for those students who have not studied well enough for their prof exam. Just a last bit push for you to sail through your prof exam. But again, I would strongly suggest that if you have studied from main videos or any of my YouTube lessons on any topic, please revise those notes itself and write your prof exam. But for the systems or the topics which you are not studied from the main videos or the YouTube lessons, you can refer to Farre. So today we will be starting with the respiratory medicine, and there are 10 important questions from the respiratory medicine, out of which 5 I will discuss on YouTube and the remaining 5 will be available to you on the MedEd's Farre notes, which you can refer for writing the answers. So let us begin with the first question itself. The most commonly asked question on respiratory medicine is about asthma. Second most common is COPD and third is pulmonary tuberculosis. So the question may go like this. Describe the clinical features, diagnosis and management of asthma. Write a short note on the new biologicals for asthma management. Now, one important tip for writing the prof exam, I'm not just telling it as a student but also as someone who corrects papers. Now, your prof paper need not look exactly like this. Means the question need not exactly look like this. The question may have only parts of a disease. In the sense, when we talk about a disease in a textbook, we talk about its definition or introduction, then the epidemiology, clinical features, diagnostic evaluation, differential diagnosis, management, and then complications. That is the usual sequence. But when you're writing a prof exam, all the components of a disease may not be asked in the question, so only write what is asked. But to just make answer appealing, always have one line or two line introduction to begin with if it is a long essay form of question, and then address only what is asked. If the question is only asking risk factors diagnosis, then only write risk factors and diagnosis. If question is asking diagnosis and management, then only write diagnosis and management. No need to elaborate everything about a disease. That will not give you any extra marks. Okay, so let me start with the first question. Describe clinical features, diagnosis and management of asthma. So as I've already told you, it's better to begin every question with an introduction. So what should be the introduction for asthma? So first point that I want you to cover in introduction for asthma is a airway disorder which is characterized by reversible obstruction, right? So asthma is a airway disorder characterized by reversible obstruction. Characterized by, the word that examiner are looking for in this question is that it is characterized by reversible. Reversible is the key word. The moment examiner sees this, he understands that you know a little bit about asthma. Reversible obstruction. Okay, after that the question may be asking you to classify the types of asthma, and when it comes to classification of asthma, there are two classifications that you need to mention. The first classification is intrinsic versus extrinsic asthma, and the second classification is type 2 and non-type 2 asthma. So you can discuss it under two headings. In A, let us discuss intrinsic versus extrinsic. Intrinsic versus extrinsic. So there are two types of asthma, intrinsic and extrinsic. What is the basis for this classification? The basis for this classification is the trigger. Whether the trigger is inside the body or it is outside the body. If the trigger that precipitates an attack of asthma is outside the body, we call it as extrinsic. So the trigger for the extrinsic asthma is usually allergens. And that's why extrinsic asthma is also called as atopic asthma. It is also called as atopic asthma. On the other hand, the trigger for intrinsic asthma is infections. So the usual story of extrinsic asthma patients is when some dust, they get exposed to some dust or some pollens, an attack get precipitated. But when we look at intrinsic asthma patients, it's like, okay, I got cold, after that an asthma attack got precipitated because I had an infection precipitated the asthma attack. right? Then second thing that you need to mention in intrinsic versus extrinsic is the onset. The intrinsic asthma generally has adulthood onset, and the extrinsic asthma has childhood onset. So most of the allergic asthmas, the onset is in the childhood, but extrinsic is in the adulthood. And then the examiners may be keen to look at whether you mention the presence or absence of Samter's triad. What is Samter's triad? Can anybody tell me? Samter's triad comprises of three things. What are those three things? One of them is, of course, asthma plus nasal polyps and aspirin hypersensitivity. Nasal polyps and aspirin hypersensitivity. Samter's triad is typically encountered in intrinsic asthma patients and not in extrinsic. And last but not the least, I would also want you to mention a word about prognosis. Which asthma carries better prognosis? Sumana and MBBS, very good, very good. Which one carries better prognosis? The childhood onset asthma generally carries better prognosis because they do not carry asthma throughout their life. Most of them grow out of asthma by the time they become teenagers or adults. They are no longer asthmatics. But if the asthma starts in the adulthood, it lives with them till the end. So that's why the prognosis of intrinsic asthma is considered as poor, and the prognosis of childhood onset extrinsic asthma is considered as good. To make sure that you don't get confused in the examination hall, when you read about intrinsic versus extrinsic, I just want you to always read it as childhood onset extrinsic asthma, adulthood onset intrinsic asthma. So this way you will remember it. You don't get confused between the two. So this is one way of classification. There is another way of classifying the asthma, and that is type 2 versus non-type 2. And the basis for this is which type of helper T cells are involved in the pathogenesis. Which type of helper T cells are involved in pathogenesis. So the type 2 is Th2 mediated, and the non-type 2 is Th17 and Th1 mediated. And why is this important? This is important because the inflammatory cytokines that are involved in causing the airway damage differ from the two types. So if the Th2 is responsible for triggering the inflammation, then the cytokines that are involved mainly include, can anybody tell me what all cytokines are involved in the type 2 asthma? In type 2, it is interleukin 4, interleukin 5 and IgE. These are the things I want you to remember. But in non-type 2, when it comes to non-type 2, we have mainly interleukin 1, 6, 17, 22. So you have interleukin 1, 6, 17, 22. The list goes on. Why is this important? Because this will have the influence in terms of management. All asthma cases we try to manage with conservative mode and simple drugs. But when simple drugs fail to control the asthma, we have to hit hard. We bring what we call as monoclonal antibodies or biologicals. So if I'm bringing a biological which primarily targets interleukin 4, 5 or IgE, then they will be useful for type 2 asthma. But if I'm introducing a biological which does not block these, but rather it blocks maybe interleukin 1, 6, 17, they may find use in non-type 2. So as of now, we don't have anything exclusively made for non-type 2, but we have drugs targeting the type 2. So we'll discuss that later when we write the role of biologicals. Okay, so this is about classification of asthma. So what we have learned so far, whenever there's a question on asthma, in the introduction, make sure you write reversible obstruction. It's an obstructive airway disorder, but the obstruction is reversible. It is not always there. Whenever triggered by an infection or allergen, obstruction comes, it disappears later. Right? Classification wise, we learned about two: the adulthood onset infection triggered intrinsic asthma with poor prognosis and Santhosh triad, and childhood onset extrinsic allergic asthma with no Santhosh triad and good prognosis. Second is type 2 versus non-type 2. Okay. After the classification, let us talk about the clinical features of asthma. So what are we expected to write in clinical features? So first word that examiner is looking for is mention episodic. Why? Because asthma is having reversible obstruction. When there is obstruction of the airway, patients experience symptoms. When there is no obstruction, they will be symptom free, right? So it's not like a COPD patient who has symptoms all along the year. Asthma, whenever there is an attack, they are symptomatic. When there is no attack, they don't have any symptoms. So the point to notice, patients will have episodic. When there is airway obstruction, they will have cough, they will have wheeze and shortness of breath. Now, if it is about a respiratory disorder, the cough and shortness of breath you can write as a standard complaint or clinical feature in all diseases. Talk about pleural effusion, pneumothorax, pneumonia, COPD, ILD, occupational lung disorders, sarcoidosis, or asthma. In all of them, they will have these two symptoms common: cough, shortness of breath. But the key word that examiner is looking for is episodic. That gives an idea that you know about the disease. Second thing, if you can write, I definitely want you to write down where do you get, which part of the day the episodes are more common or asthma attacks are more common. Symptoms are usually more common at night or early mornings. Symptoms are more common at night or early morning hours. Right? This is about the clinical features that you need to write. Now this is the symptom wise. On examination, what findings we can expect in a patient with asthma? Only findings that we can get on examination is during the episode of asthma attack. If I examine a patient when he is not going through asthma attack, his lungs may be fully clear and perfectly normal. So during episodes, wheeze may be heard on auscultation. Okay, this is what I expect you to write down in the examination. Now, if clinical features are listed, the next question is diagnosis. So what do I expect if I'm correcting a paper on diagnosis? The first thing I would expect is you should mention what is the investigation of choice. What is the investigation of choice for asthma? The investigation of choice for asthma is PFT. Asthma is not diagnosed based on chest X-ray. PFT is the investigation of choice. And what are the findings we get on PFT? The PFT findings, asthma is an obstructive disorder, right? So what are we expecting? The FEV1, what is going to happen to FVC, and what is going to happen to FEV1 by FVC ratio. So FEV1 is decreased significantly. FVC may be normal or slightly decreased. And when we look at the ratio, it will be less than 0.7, which is classical of the obstruction. And this is the point that examiner is interested in seeing in your answer paper. You should mention FEV1 by FVC less than 0.7. Does it prove that patient has asthma? No, it only proves that patient has got an obstructive airway disorder. So it is good if you mention that this finding is suggestive of obstructive airway disorder. This is not proving that he has got asthma. Then how do I prove that he has got asthma? I have to prove that he has got asthma by doing what we call as the bronchodilator reversibility test. This is first thing. PFT is the investigation, and then you have to mention bronchodilator reversibility test, because asthma is characterized by reversible obstruction. Yes, good. Bronchodilator reversibility test. How much it is? Not 20%. 20% is if you are using PEFR, peak expiratory flow rate. Here what we are using? FEV1. So if FEV1 increases by more than 12% or by 200 ml. So you can write in asthma, FEV1 increases by more than or equal to 12% or more than or equal to 200 ml. And what does it suggest? It is suggestive of a reversible obstruction. And always make it a point that whenever you're writing, because writing is also an art, it's not a random stuffing of information. So try to use tables and flowcharts. So whatever we discuss now, you can put it on a flowchart as well. So if you are having a suspected patient of asthma, the next step you are expected to do is go for the PFT. And in the PFT, you are looking at FEV1 by FVC the ratio of less than 0.7. And if it is less than 0.7, you know that it is obstruction. So then you are going for bronchodilator reversibility test. So what do we do in bronchodilator reversibility test? We have patient's baseline FEV1 value known to us. And after that, we administer a short acting beta agonist, and we will check post bronchodilator FEV1. And if this FEV1 increases by more than or equal to 12% or 200 ml, then it is reversible obstruction, and all reversible obstruction for all practical purpose is equal to asthma. It is equal to asthma. On the other hand, if there is less than 12% increase, it is suggestive of persistent obstruction. So what other obstructive disorders you know? So persistent obstruction could be seen in COPD or patients with bronchiectasis. Patients with bronchiectasis. The same flowchart you can replicate for the COPD as well. In the COPD also you can write suspected COPD. You do PFT, ratio is less than 0.7. You do the bronchodilator reversibility test. And if you get less than 12% increase, then it is persistent obstruction. Then it is suggestive of COPD, right? Stick it here, stick it in COPD as well. This makes your answer sheet beautiful, and you may get half to 1 mark extra from your examiner. Now that we have done about diagnosis, one extra point which is relevant also. See, this FEV1 by FVC ratio of less than 0.7 will only come when patient is going through an attack of asthma. If you do a PFT in between two attacks, the FEV1 by FVC ratio may be perfectly normal because he is not going through obstruction then. In such cases, how would I diagnose asthma? We can still prove that, see, in bronchodilator reversibility test, what did we do? We tried to see whether the obstruction is reversible or not. But we can also do a test whether I can induce obstruction or not. If some trigger induces obstruction, that means patient is having airway hyperresponsiveness, and that means he is having asthma, right? So can anybody tell me which test can be used for airway hyperresponsiveness precipitation or proving that his airway is hyperresponsive and thus he may be having asthma? So first point is always about PFT. Second, you can write about airway hyperresponsiveness. Yes, the methacholine challenge test. So you can do something called as methacholine challenge test. But can anybody tell me why am I using methacholine here? To precipitate an attack of asthma. How does it help to precipitate an attack of asthma? Remember the bronchoconstriction. How will bronchus constrict? The smooth muscles in the bronchi have to contract, then only it will constrict. And the smooth muscles in the bronchi are under the autonomic nervous system control. Sympathetic nervous system causes bronchodilation. That's why we use the beta agonist sympathetic drugs to cause bronchodilation, right? Short acting beta agonist is what we used here. And then parasympathetic causes bronchoconstriction, sympathetic dilatation, parasympathetic bronchoconstriction. So acetylcholine is the main neurotransmitter of parasympathetic nervous system. So we are using something very similar to acetylcholine, which will act as a parasympathetic agonist and cause bronchoconstriction. So how is this test performed? We will check the patient's baseline FEV1 and then we will administer methacholine. We will administer methacholine and we will check post methacholine FEV1. And if it dropped by more than 20%, why will it drop? Only when airway constricted severely it will drop. If it did not constrict, it wouldn't drop. So if it dropped by more than 20%, then airway hyperresponsiveness is present and you can say that this patient is having asthma. Decreased by more than 20%, that means airway hyperresponsiveness is present, and for us that is equal to asthma. But if there is less than 20% decrease in FEV1, then we would say there is no airway hyperresponsiveness. So probably it's not a case of asthma, right? That is going to be our approach. So that's about the diagnosis. So in the diagnosis, mainly write about PFT. If you can remember, write about airway hyperresponsiveness. If not, you can ignore. The fractional exhalation of nitric oxide we will discuss when we talk about the management. Okay. So this is about diagnosis. The next thing that you need to write about is the management. Now, management of asthma is guideline based, but unlikely that they will ask you to elaborate on the guidelines for the management of asthma in a prof exam. Your MCQs will be based on the guidelines, but in the prof exam, it is about giving an overall picture of the management of asthma. So you have to primarily begin by listing down the drugs of pharmacotherapy available. And you can write 1 or 2 points about pros and cons or the benefits and adverse effects or side effects of each class of drugs. So when it comes to asthma management, the drugs will be classified as relievers and maintenance medication, right? So the first class of drugs are relievers. So what are the relievers? Relievers are those drugs which treat an attack of asthma once it is already in place. Like I'm going through asthma attack, now I want to relieve it. Those are called as relievers. And the maintenance medications are the ones which prevent the attack from occurring. So relievers are used to relieve an attack of asthma once it is set in. Relieve an attack of asthma once it is set in. Just give me 1 second, guys. My pencil got hanged. Okay, so relievers are the ones which are used to relieve an attack once it has already started. These drugs have to have a very quick onset of action. The maintenance medications are the ones which prevent an asthma attack. So they should have a long duration of action. That's a basic point you need to know. So relievers are used to relieve an attack of asthma once it is set in. The examples are short-acting beta agonist and short-acting antimuscarinic agents. And you should also make it a point that short-acting beta agonists are preferred agents. Preferred agents, and you can write one example as well. The example for SABA is salbutamol. And an example for SAMA, ipratropium is atropine is an anticholinergic, right? Another antimuscarinic. The names that end with or similar to atropine, ipratropium, tiotropium. These are all antimuscarinic agents. Ipratropium is short acting, tiotropium is long acting. So relievers are going to be short acting agents. And then we will have maintenance medications. For maintenance, we will use long-acting beta agonist or long-acting antimuscarinic agents, but it should also be combined with steroids because it is the TH2 or TH17, which is initiating all the inflammatory cascade. So these are medications used to prevent asthma attacks. So under this you can mention long-acting beta agonists and long-acting anti-muscarinic agents and inhaled corticosteroids. And you know that LABA is preferred and ICS is preferred. LAMA is not the first choice long-acting or maintenance medication. The examples for LABA currently formoterol, which is rapid onset long-acting beta agonist, salmeterol, these are LABA. And an example you can write for LAMA is tiotropium. And inhaled corticosteroids that can be used, examples, you have budesonide, beclomethasone, these are all inhaled corticosteroids. These drugs are considered as the pillars of management of asthma. Okay. So if you want, you can also write down preferred reliever and what is the preferred maintenance medication. The preferred reliever is formoterol, and today we do not give the SABA alone, we always give it with inhaled corticosteroid. And for the maintenance also, formoterol is the preferred medication along with inhaled corticosteroid. So in terms of efficacy, the beta agonists are more effective than the anti-muscarinic agents. So that's why we prefer beta agonist. But in COPD, yes, we prefer LAMA over LABA. There are advantages that I will discuss when we talk about the COPD. But when it comes to asthma, in terms of effectiveness, beta agonists are more potent than the anti-muscarinic agents. And of course, we need more potent drugs here. That's why we are using LABA. This is the basic structure of your answer. But then the question may ask about role of biologicals. So in a prof exam, you don't have to write an elaborate discussion on when do we introduce biologicals, the steps of GINA guidelines. All of that is not required. You will not have that much time also to write. So rather keep it crisp. What I want you to mention is they're considered in cases refractory to inhaled therapy. So when we use inhalers and patients fail to respond, in those cases we consider biologicals. So what are the biologicals available? Yes, one of you already mentioned omalizumab. Omalizumab is an answer that you cannot miss. Your examiners are closely looking for it in biologicals under the heading of biologicals. Omalizumab, which is a anti-IgE monoclonal antibody. So now tell me, is it useful for a type 2 asthma patient or non-type 2? So in type 2 is where IgE is involved, right? So then omalizumab is only useful for type 2 asthma. It is not useful for non-type 2 asthma, right? Because IgE has no role to play here, right? Similarly, if I have drugs targeting IL-4 or IL-5, they will have only role in type 2 asthma. Good, very good. So second drug I want you to mention is dupilumab. Then we have mepolizumab, reslizumab, benralizumab, and a new drug called as tezepelumab. Okay, so dupilumab is anti-interleukin 4 receptor, anti-IL-4 receptor. Mepolizumab and restylizumab are anti-interleukin 5, and benralizumab is also targeting interleukin 5, but not directly. It is targeting its receptor. And tezepelumab is a new drug targeting TSLP. What is that? I'll tell you now. So now tell me, IgE is in type 2, so omalizumab is for type 2. Dupilumab IL-4 is also in type 2, so that is also for type 2. IL-5 is also in type 2, so that is also for type 2. So these are used for type 2 asthma. Okay. On the other hand, this anti-TSLP, TSLP stands for thymic stromal lymphopoietin. Thymic stromal lymphopoietin, which is just like erythropoietin, thrombopoietin, right? We have GM-CSF. It's a colony stimulating factor that stimulates all types of T cell proliferation, Th2, Th17. So if I block it, Th2 activity as well as Th17 can come down. So this is useful for both type 2 as well as non-type 2. For both type 2 and non-type 2. And this is what pheno. Now I just told you that we use so many drugs for type 2, but for non-type 2 I have only one, that is tezepelumab. But how will I get to know whether my patient has got type 2 asthma or non-type 2? And for that we do biomarkers. So if any of these biomarkers are elevated, it is pointing towards type 2. If they are not elevated, it is pointing towards non-type 2. So what are those? The first one is absolute eosinophil count. So if eosinophil count is high, it is suggestive of type 2 asthma. Second, serum IgE levels. If serum IgE levels are high, it is pointing towards type 2 asthma. Third is called as fractional exhalation of nitric oxide. If that is high, it is pointing towards type 2 asthma. So when this is added, your answer is perfectly complete for the asthma. With this, if there's a 10 mark question, if all these points are addressed, you will definitely get more than 7.5. If you miss out any of these, you will still get close to 7, but keep the structure simple. Write 1 or 2 lines about introduction, mention reversible obstruction, definitely talk about the classification if it is asked. Clinical features, don't elaborate too much. Make sure you mention episodic symptoms, and symptoms of worse or attacks frequently happen in early mornings. For the diagnosis, PFT, at least if you cannot write, put the flow chart. Investigation of choice, PFT. PFT should show FEV1 by FVC ratio less than 0.7, and reversibility should show more than 12% increase in FEV1 or 200 ml increase in FEV1. In terms of management, mention reliever and maintenance. These words are what examiners are looking, so that they know what is used to relieve an attack and what is used to prevent an attack. And then write 1 or 2 sentences about biologicals. If you can put a table, drug on one side, target action on the other side, you're done. Okay. Now next I will take you through Sutapa. Did I miss your question? See, okay. I did not want to get into the conceptual discussion of asthma, but because you have asked, let me address this point, because which is very, very relevant. The case presentation in the bedside, your teachers also may ask this. In Viva OSCE, they might ask this. Why corticosteroids are always combined with the beta agonist? Well, something comes down to the bronchial smooth muscles. So when we look at the bronchi, why asthma attack happens? Because airway got challenged by some trigger, infection or allergen, depending on intrinsic or extrinsic, and there was activation of Th2 or Th17, and there were recruitment of inflammatory cytokines, right? Inflammatory cytokines came and caused the inflammation of the airway. One side we have airway inflammation, second side there is irritation and triggering of the bronchial smooth muscles which constrict, and that's why we get that obstruction, right? Every time bronchial smooth muscle constricts, muscles have a tendency to develop hypertrophy if they overwork. If you go to gym and keep lifting heavy weights, you will build muscles. Your bronchial smooth muscles, they keep constricting again and again. They are also doing a gym workout. So they will develop hypertrophy. And the bronchial smooth muscle hypertrophy means what? They are becoming stronger and stronger. So with passage of time, the bronchial smooth muscle strength increases, the force of contraction increases, and the asthma attacks start becoming more and more severe. So on one hand, we have to prevent smooth muscles from becoming hypertrophied. On the other hand, we have to prevent the inflammation is the root of all these problems. The Th2, Th17 cells, they are the root of all these problems. So I have to prevent the inflammation as well. So by giving long-acting beta agonist, I can prevent this bronchial smooth muscle from constricting because beta agonists are bronchodilators. But what about the inflammation? The inflammation also need to be prevented. And how will I prevent? With steroids. So if I don't bring steroids, then I will require very high dose of beta agonist to prevent the constriction. And with that high doses, the side effects of beta agonists goes on increasing even with inhaled route. And the airway remodeling, the smooth muscle hypertrophy and other airway changes that happen, goblet cell hyperplasia, all of that will progress faster. So the best way to deal with any disease, not just asthma, is try to address everything that is contributing to the pathogenesis of a disease, not just only one element. Symptomatic treatment is not the goal. Modifying the disease is the goal. Okay. Now let's go to the, I will cover ILD as well. Okay. So now let's go to the next question, which is on COPD. The question may go like this: discuss the risk factors. In asthma, they may not ask you to talk about risk factors, but COPD, well-established risk factors are there. So they expect you to discuss risk factors, clinical features, diagnosis and management. And when it comes to clinical features, it is better to discuss under two separate headings: the chronic bronchitis as well as emphysema, right? So let us first begin with the introduction as usual. What is the introduction you would like to give for COPD? This is also an airway disorder, just like asthma, characterized by obstruction. But what is the difference? COPD is characterized by persistent obstruction. Asthma is characterized by reversible obstruction. So this is an obstructive airway disorder. An obstructive airway disorder characterized by persistent obstruction. And I would also expect you to mention the cause for this persistent obstruction in the definition itself or introduction itself. Caused due to chronic exposure to. Don't write smoking. Smoking is not the only cause. Noxious gases, harmful gases. Now, being in Delhi itself may be a risk factor for development of COPD in the near future, because you know the AQI and the amount of noxious gases you may end up inhaling if you are in such polluted places. So the word is noxious gases, harmful gases. Smoking is one of those harmful gases. Now, if we have to talk about the risk factors, of course, the most common risk factor is smoking. And when we talk about smoking, it's not only the cigarette or BD, right? So it's not only the cigarettes or BD, but even, what is that called? Hookah and e-cigarettes. E-cigarettes are not absolutely safe. They also emit minute less than PM 2.5 particles, which can trigger COPD. So nothing is safe. So smoking is the most common risk factor, right? And then second most common risk factor is burning of biomass fuel. Means the wood logs, cow dung patties that is used for cooking, right? That is biomass fuel. Burning of biomass fuel also is a risk factor. It is good if you mention that it is the most common cause for COPD in non-smoking females. Then genetics, and when it comes to genetic risk factor, you are expected to mention particularly alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency. And now you can definitely write the air pollution as a risk factor. In the past, we used to say that there is no causative relationship established. Air pollution is only considered as a precipitating factor when it comes to COPD, but all the recent studies done over last 10 years are pointing towards even air pollution as a risk factor for COPD. You might never smoke, but still end up with COPD if you live in polluted environment, right? So these are the points you need to mention. Kunal Kishore, yes, the notes will be available on the PW MedEd's Telegram channel, and soon after the class it should be made available to you. Okay, right? So these are the 4 points you have to mention in risk factors. Now the next part of the question is clinical features, and it is better if we discuss clinical features under 2 separate headings, because there are 2 subtypes in the COPD. One is chronic bronchitis and the other one is emphysema, right? So better to begin with the emphysema. So first, when you put the title, I want you to mention what is emphysema. What is emphysema? Sudhapa, depends on which part of the respiratory system a disease is affecting. So if a disease is affecting an upper respiratory tract, we classify the respiratory system into upper and lower. So from the nose till the end of larynx is upper respiratory tract. Larynx, below larynx, that is trachea, bronchi, and the lungs is lower respiratory tract. Your inhalers will never be able to reach the trachea. So if there is a pathology in the trachea, bronchi, or lungs, you have to either use inhaled drugs or you have to use systemic drugs. Only in the upper airway diseases, the nasal drops may be of some use. Okay. So emphysema. What is emphysema? Emphysema is defined as irreversible dilatation and destruction of acini. Now the question is, what is an acinus? What is an acinus? Acinus is part of the airway that begins with the respiratory bronchiole and ends with the alveolar sac. So acinus, if I talk about the trachea, this is the trachea that divides into 2 bronchi, and the bronchi will go through multiple generations of divisions, and eventually after multiple generations of division, they become what we call as a respiratory bronchiole. So this green line, think of it as respiratory bronchiole. Respiratory bronchiole. And the respiratory bronchiole might branch into what we call as alveolar ducts. Alveolar ducts. And alveolar ducts lead to alveolar sacs. Alveolar ducts eventually lead to alveolar sacs. And all this put together means one respiratory bronchiole, all of its alveolar ducts, in whatever number of alveolar ducts it divides into, and whatever number of alveolar sacs it leads to, all of it put together is called as one acinus. In this whole structure, one respiratory bronchiole, its alveolar ducts, and all of its alveolar sac together is one acinus, right? So you can mention it in the paper if you want to. Acinus is equal to respiratory bronchiole plus alveolar ducts plus alveolar sacs. So when they become irreversibly dilated, we call it as emphysema. So if it becomes irreversibly dilated, the structure becomes dilated, we call it as emphysema. Now emphysema is further classified into, if you know from your pathology, it is classified into centriacinar, panacinar, and distal or parasector. So it is wise if you can put pictures of it. So each acinus begins with an respiratory bronchiole that branches into alveolar ducts and alveolar sacs. So this is respiratory bronchiole, alveolar ducts, and these are alveolar sacs. So if only respiratory bronchiole gets dilated and rest of the structures are unaffected, then it is called as, so only respiratory bronchiole is dilated, then we call it as centriacinar. This type of emphysema is called as centriacinar emphysema. And if the whole of it, means respiratory bronchiole, alveolar ducts and alveolar sac, everything gets dilated, then we will call it as panacinar. Then we are going to call it as panacinar. So can anybody tell me, centriacinar is more common in smokers or panacinar is more common in smokers? And if only alveoli get dilated, then it is called as paraseptal or distal acinar. Only the sacs get dilated, then it is called as paraseptal or distal acinar. Yes, the smokers tend to get centriacinar, and alpha-1 antitrypsin deficiency tend to get panacinar. This type is called as paraseptal or distal emphysema. So this is more common in smokers. Even paraseptal is more common in smokers. While if alpha-1 antitrypsin deficiency is responsible for someone developing COPD and emphysema, they are more likely to get panacinar, right? So this is what you are expected to write in emphysema. So this is basic introduction to emphysema. What clinical features these patients are going to present? Can anybody tell me what clinical features these patients are going to present with? Emphysema patients, I'm not talking about chronic bronchitis. This acini is irreversibly dilated. They are irreversibly dilated. Is it easy for the patients to breathe the air in if I have emphysema, or is it easy for me to breathe the air out? This is the airway, and this part is dilated. It's dilated. Now, to understand the emphysema, I want you to understand two basic principles of physics. Anything that is fluidic in nature, which can flow, be it air or fluid, water, air, anything that is fluidic in nature, moves from high pressure to low pressure zone. That is first thing. Second thing I want you to remember is Boyle's law, which says pressure has an inverse relationship with volume. Every time any of this space or a chamber or a container, its volume is decreased, its pressure increases, or vice versa. If volume increases, pressure decreases. So now tell me, is it easy for me to bring the air into this dilated emphysematous part of the airway, or it is easy for me to pull the air out from this? If I dilate, according to Boyle's law, the volume increased, and if volume increased, the pressure decreased. So if the pressure is low here, and it makes it easy for the air to come into this area from the atmosphere, pressure is low. But to exhale, I have to increase the pressure. Normally the airway recoils, volume decreases, pressure increases, and that is how the air leaves and goes to the atmosphere. But here these are irreversibly dilated. They are irreversibly dilated, so they will not recoil. So if not, then they will not be able to increase the pressure. So the air can come in easily but can't go out easily. So what is the problem that these patients are going to face? Struggle to exhale the air out. Struggle to exhale the air out. Can they do some physical modifications that help them to exhale the air? See, the only provision that physics has given us to exhale is to increase the pressure in this part of the airway. How can I increase? Normally I increase by recoiling the airway, but it's not going to recoil. What I can do? What if I press the diaphragm up? If I push the diaphragm up, I'm making the whole volume of the thorax reduced. Volume reduced means pressure increased. So pressure will increase here also, and that makes it little easier for me to exhale, right? And now let us take the example. I have this container, okay, some solution container here. Now if I want to expel the content of this container out after removing its cap, okay, when is it easy for me? I mean, when will I be able to see? First thing, we have to agree that I need to increase the pressure in this part of the airway, okay. When I will be able to increase the pressure and push the content of this container far, is it by completely opening this and then squeezing, or keeping it partially open and then squeezing? Which is a better idea? Completely open and squeeze, or partially open and squeeze to bring the content of this container out? The more wider the opening, when I try to squeeze, the pressure build up inside will be less, so less amount will spill out. But more narrower the opening and I squeeze, the pressure build up inside will be more, so more will be squeezed out. So that's why when we want to squeeze this ketchup, if you open a ketchup container completely and squeeze, little pops out, but keep it the cap that opening small and then squeeze, you will be able to squeeze out large. So don't you think these people will also be helped if they keep the mouth opening small while breathing? More open it is, the whole airways pressure will be low. But if they keep the mouth partially closed, they will be able to build higher pressure inside the airway, and it makes it easier for them to exhale the air. So two things are going to help them. Pushing the diaphragm up, whole lung gets squeezed, so becomes easier to exhale. Second, keeping the mouth partially open. So what do we call this partially open mouth? Yes, so emphysema clinical features are: number one, when they walk into the hospital, you will notice that they have pursed lip breathing. By pursing the lip, inside the airway pressure increases, so that helps me to bring the air from that dilated segment out. Pursed lip breathing. Second thing they will do is, they will, if you see the COPD patients, especially emphysema patients, they don't lean back and lying in the bed in the hospital if you go to take a case. They're always sitting, leaning forward, their elbows or hands resting on the thighs. We call this as tripod position, because when they do that, diaphragm is pushed up, pressure inside the thorax increases. That helps them to exhale little more easier. So we call that as tripod positioning. If you want, you can put a small sketch. So when they are lying, sitting down, they are resting their elbows on the thigh. This is what we call as tripod positioning. So they have pursed lip breathing and tripod positioning. Third, because air is able to come into this dilated alveoli easily but not able to go out, the air is getting trapped in the lungs. So the size of the lung starts increasing. And to accommodate this increasing size of the lung, the chest also have to increase. Unfortunately, chest cannot increase in size horizontally, because the ribs are attached anteriorly and posteriorly, anterior to sternum, posteriorly to the vertebral bones. So if I have to expand the chest horizontally, I have to rip them apart. Not possible. So only increases anterior-posterior diameter. And increasing anterior-posterior diameter makes the chest appear. Normally, when we look at the chest, it is little more flat. It has more horizontal diameter than anterior-posterior. But if anterior-posterior increases, it will become equal. Horizontal as well as anterior-posterior diameter will become equal, and we call it as barrel-shaped chest. Yes, we will call it as barrel-shaped chest. If you want, you can put a picture also. So when we look at the normal chest, the normal chest has relatively more width, and the barrel-shaped chest is perfectly circular. So normal, the transverse diameter by anterior-posterior diameter ratio. If you look at that ratio, in a normal chest, it will be transverse diameter will be 7, anteroposterior will be 5, or you can write it as 5:7 if you write anteroposterior on top and transverse at bottom. But in case if it is 1:1, then we call it as barrel shaped chest. So this is how normal chest looks like, and this is going to be the barrel shaped chest looking like. So this transverse diameter will be 7 and anteroposterior diameter will be 5. Here both 1:1, means 7:7, that's 1:1. So these are the key findings that we get in emphysema, right? These are the 3 things you need to write. Now after emphysema, we will also talk a little bit about one more subtype of COPD, that is going to be chronic bronchitis. So can anybody define it for me? What is chronic bronchitis? Emphysema was irreversible dilatation and destruction of asthma. What is chronic bronchitis? As the name says, chronic inflammation of the bronchi. The definition is not pathology. Definition here is more clinical. The emphysema definition is pathology based, right? Clearly, asthma are dilated, irreversible. Then you call it as emphysema. But the chronic bronchitis definition is clinical. So a patient has got productive cough. Yes, good. Crazy loser, very good. So productive cough. Productive means cough with sputum. Productive cough of more than or equal to 3 months per year for 2 consecutive or successive years. Consecutive years means last year patient had at least 3 months of cough with sputum. This year also he has at least 3 months of cough with sputum. Then we will call it as chronic bronchitis. Now what symptoms these patients are going to present with? In terms of clinical features, emphysema patient present with pursed lip breathing, tripod positioning and barrel shaped chest. These patients main presenting complaint will be cough with expectoration. Cough with expectoration or sputum production. Okay. What else we can expect? So I forgot to mention this. It is good if you write it down in your answer sheet. The patients of emphysema are also known as, emphysema patients are also known as pink puffers. They are also known as pink puffers. Why are they called as pink puffers? Number one, they are called as pink because there is no cyanosis. They are not going to look bluish. And they are called as puffers because their lungs, because of this air getting trapped in this dilated segment, they are becoming like puffed. You know, egg puff, veg puff goes inside the oven small and then gets puffed by trapping air. Similarly, these people's lungs are getting trapped by, the air is getting trapped in the lungs. So we call it as puffed lungs. So it's why we call it as pink puffers. Now these patients of chronic bronchitis are also known as blue bloaters. They are also known as blue bloaters. Why are they called as blue bloaters? Well, number one, they're called as bloaters, blue, because there is cyanosis. Why there is cyanosis? The chronic bronchitis causes the obstruction of the airway and the amount of oxygen reaching the alveoli decreases. So there is hypoxia that is causing the chronic, that is causing the cyanosis. So that's why these are called as blue. But why are they called as bloaters? See, these bronchi are inflamed, less oxygen comes to the alveoli. So they have hypoxia, they have cyanosis, so blue. But why bloaters? So in common English, puff refers to something swollen because of air being trapped. Veg puff, egg puff, puffer fish, they trap, hold air and appear big. The word bloated is used whenever something increases in size because of fluid accumulation. Fluid accumulation. When you get up in the morning, eyes look bloated, right? So the fluid accumulation is like the term bloated is usually used for fluid accumulation in something causing it to increase in size. So why are we using that term for these patients? So as the amount of oxygen reaching the alveoli comes down, the pulmonary capillaries which are there here to receive this oxygen, they go into constriction. And because of the constriction, pressure behind this increases. Behind means pulmonary artery, which is bringing the blood from the right side of the heart for oxygenation, right atrium, right ventricle. So from right side, pulmonary artery is bringing the blood to lungs for oxygenation. And these capillaries get constricted. And if they get constricted, behind that there is increase in the pressure. That is pulmonary hypertension. So chronic bronchitis leads to pulmonary hypertension. Because of the pulmonary hypertension, right side of the heart can fail. And once the right side of the heart fails, right atrial pressure increases, inferior vena cava, superior vena cava pressure increases, you start developing edema. Because inferior vena cava pressure is high, fluid doesn't drain to the heart easily, so you have edema. So the word bloated comes because you are developing edema, and this is what we call as cor pulmonale. Right side of the heart failed because of lung problem. Why it failed? Because you had chronic low oxygen entering the alveoli that caused pulmonary capillaries to constrict. Because of that, pulmonary artery pressure increased. Because of that, right ventricular pressure increased, right atrial pressure increased, right heart failed to deal with the situation, inferior vena cava pressure increased, and you ended up with edema, hepatomegaly, the classical right heart failure symptoms. So when lung problem caused right heart failure, we call it as cor pulmonale. So in Viva OSCE, your teachers might ask you, emphysema is more likely to cause the right heart failure or chronic bronchitis? It is the chronic bronchitis which is more likely to cause the right heart failure. And the word blue comes because of cyanosis, and bloater comes because they are getting edematous, they are getting bloated. Okay. So make sure you write that they are called as blue bloaters. And apart from this cough with expectoration, I would expect you to also mention that they may have cyanosis, and I want you to mention that they are prone to develop pulmonary hypertension and right heart failure. And in the bracket you can mention that this pulmonary hypertension and right heart failure that we are talking about is technically called cor pulmonale. So once this is written, your discussion on clinical features of the COPD is done. You have elaborated them under two headings, the emphysema and chronic bronchitis. After that, then comes the talk about diagnosis. How will you diagnose a case of COPD? So for COPD also, the investigation of choice is going to be PFT, because PFT picks up the obstruction easily, right? So what is the expected findings in PFT? When you look at FEV1 by FVC ratio, just like asthma being an obstructive disorder, it is expected to be less than 0.7, and as we know, that is only suggestive of obstruction. And then when we do bronchodilator reversibility test, in asthma we have mentioned that 12% or higher increase in FEV1 is expected after giving a short acting beta agonist. Here we will get less than 12% increase in FEV1. If it is more than 12%, it's clearly pointing towards reversible obstruction, and that means it's a case of asthma. Now, it is also wise to write 1 or 2 sentences about the chest X-ray in COPD. What are the findings we are going to get in COPD on the chest X-ray? Chest X-ray is not good for detecting the chronic bronchitis, but it is good for detecting emphysema. Can detect emphysema. And what are the findings we will get? Emphysema means irreversible dilatation of the alveoli. More air is trapped in those irreversibly dilated areas of the lung. So because of more air being in the lungs, the air is the one which is responsible for a darker appearance of the lung fields. More air, you will have more darker lung fields. So that is the first finding. You will have darker lung fields. Second, because of the lungs size expansion, you will have widening of the rib spaces. Widening of rib spaces. Third, the expanding lungs will try to push the diaphragm down and the mediastinum squeezed. From both the sides, lungs are expanding, mediastinum gets squeezed. Squeezed mediastinum makes the heart appear like a tube. So we will call that as tubular heart. It's called as tubular heart. And then the diaphragm getting pushed down. Normally diaphragm appears as a dome. The dome appears flattened. So you will have flattened domes of diaphragm. Domes of diaphragm. So these are the X-ray findings we are expecting. If you can remember and write X-ray findings, it's okay. If not, it's fine. As long as you have written about the PFT for diagnosis, it's fair enough. If you have written about X-ray findings, the examiners might consider giving half a marks extra. That's it. But the main thing is about the PFT. Okay. Now that we have also learned about diagnosis, let us talk about management. But before that, because when I went through university papers, plenty of university papers are asking about the GOLD grading of COPD. GOLD stands for Global Initiative Against Obstructive Lung Disorders. We follow its guidelines for the management of COPD, and they have a grading of the COPD severity. GOLD grade 1, 2, 3 and 4. So we'll put a small table or write down about the GOLD grading. It's pretty easy to remember, and then we will talk about the management. So it is based on post bronchodilator, means we did a bronchodilator reversibility test and checked the FEV1, and we saw how much it increased from the baseline value, right? That's how we do bronchodilator reversibility test. So after giving bronchodilator, the value that we get, that FEV1, that is the post BDR FEV1, that value is used. Post bronchodilator FEV1 is used for grading the COPD. Okay, so the first is GOLD grade 4. So I'll start with the bottom, that is easier for us to remember. So GOLD grade 4 is when your post bronchodilator FEV1 is less than 30% of predicted value, and if it is between 30 to 50%, then we will call it as GOLD grade 3. If it is 50 to 80%, then we will call it as GOLD grade 2. And if it is more than or equal to 80%, then we will call it as GOLD grade 1. So easy to remember. Start at the bottom, less than 30%, 30 to 50, 50 to 80, and more than 80. Now some of you may be confused on this point. Sir, 12% increase in FEV1, it's asthma. Here you're talking about 30%, 50%, 80%. So please let me make it very clear by giving you an example so that you don't have this recurring confusion in your mind. Let us say that I check the FEV1 of a person. I'm just taking a very hypothetical number. Let us say it was 3 liter. The FEV1 before we did the bronchodilator reversibility test was 3 liter. Okay, so this is the value I got. And after that, let us say we did a bronchodilator reversibility test, means we administered a salbutamol or any other SABA, and the FEV1 I got now will be called as post bronchodilator FEV1, and this value that I got is 3.6 liter. 3.6 liter. So this is post bronchodilator FEV1. Now compared to the previous FEV1, how much percentage increase I got? I got 20% increase. 3 liter to 3.6 liter is 20%. So if this patient had obstruction, FEV1 by FVC ratio is less than 0.7, then this patient will be called as having asthma, right? But instead of that, let us say instead of 3.6 liter, I got 3.1 liter. How much percentage improvement I got? Definitely less than 12%, because if it is 12%, for every 1 liter 120 ml should increase. So for 3 liter 360 ml should increase. 3 liter 3.36. If that was my answer, then it is asthma. It is less than that, less than 12%. So that means this patient is having COPD. Now this value is what I'm using, not how much percentage increased. How much percentage increase is used only for deciding whether it is reversible or persistent. Now once I know it is persistent, for grading I'm using this value. Okay, now then from where these percentage numbers are coming? So first thing is that when we talk about FEV1 or FVC, is there a fixed normal number? Like 3.5 is normal, less than 3.5 is low? No, the number depends on your age, your gender, your ethnicity, and so many factors. Do you think my lungs will have the same capabilities as a 6.5 feet tall muscular African male? Of course not, right? His lungs capacity will be more. So the normal for him is different, normal for me is different. So every time you interpret a PFT, you come across this term called predicted. So when we do a PFT, in the machine we feed your age, your gender, your ethnicity, whether you're Indian, African, Caucasian, whatever is your ethnicity. And based on the population data, machine will decide for your age, gender, and ethnicity, and your height, weight, other measurements, what is considered as normal value. And the machine will express, compared to that normal predicted for you, how much you achieved. Let us say that for this about is vaccination. If you may ask, sir, why vaccination is important? Please remember, infections are the most common cause for COPD exacerbation. What do I mean by exacerbation? Worsening of symptoms. Like COPD symptoms are persistent because there is persistent obstruction. So these patients keep coughing, they are short of breath, they are pursing their lip, they're using the tripod position. But then suddenly one day their symptoms become more worse. And the reason for the symptoms to become worse on that day is most likely going to be some infection. And that's why at least those infections that can be prevented should be prevented, right? So vaccinations are one way of preventing infections. So what are the vaccinations recommended? So the first vaccine that is recommended is pneumococcal vaccine, because pneumococcal infections, streptococcus pneumonia infections are the most common cause for COPD exacerbation. Second is influenza vaccine. Consecutive years means sequential years, like 25, 26, 2025, 2026. It can't be like in 2015, sir, I had 3 months of cough with sputum, and 2025, I had 3 months of cough with sputum. 2 years you have cough with sputum, but they're not sequential years, 10 years of gap in between. No, without a gap. Last year 3 months, this year 3 months. Then it is called as chronic bronchitis. Pneumococcal vaccine, influenza vaccine, and diphtheria, tetanus, pertussis vaccine. These are the vaccines which are recommended for the COPD patient. Second, inhaled medication. So what are the inhaled medications that we would give for a COPD patients to relieve their obstruction? The obstruction cannot be completely relieved because it is persistent. Whatever help we can do with inhaled medications, we can do. So when it comes to inhaled medications, because asthma is episodic, so whenever there's an attack, we need a quick reliever. That's why we had a reliever and a maintenance. When it comes to COPD, it is persistent obstruction. So we always use long-acting agents. The role of short-acting agents is minimal. Only during exacerbations we might use. So inhaled medications are mainly either we can use LAMA or we can use LABA. LAMA or LABA, or a combination of both. Now LAMA is the preferred medication for COPD. LABA was preferred for asthma, but for COPD, LAMA is preferred. Why LAMA is preferred? In terms of efficacy, it's not greater than LAMA, but it has an added advantage. So what is the added advantage? Not required for you to write in the answer sheet, but in the Viva OSCE, your teachers might ask. Why would you prefer LAMA over LABA for COPD and LABA for asthma? LABA was pretty simple. It is more potent bronchodilator. But then why are we using LAMA? LAMA has an added advantage. LAMA is anti-muscarinic. So can anybody tell me what are the common side effects of atropine? See, LAMA is nothing but an atropine-like drug given in inhaled route, like the tiotropium. Example for LAMA, ipratropium is SAMA, tiotropium is LAMA. Can anybody tell me side effect of atropine? So that depends. See, pneumococcal vaccine is once in a lifetime. Influenza keeps changing, so you need to give every year. Yes, dry mouth, increase in respiration, very good. So generally all our glands, sweat glands, salivary glands, lacrimal glands, right, they are under the parasympathetic nervous system control. So parasympathetic activity stimulates glands to secrete and parasympathetic blockers inhibit it, right? And nobody questioned me why infections are so common in COPD patients. It's not about the lack of immunity. Infections are common because in COPD there is goblet cell hyperplasia, right? And tell me what goblet cells produce. So in COPD, goblet cells are increased in number because of the chronic inflammation caused by smoke. So if there is increase in goblets, there is increased mucus production. And this mucus provides a perfect environment for the infections to thrive. It's like in microbiology you study, culture media. So you need that perfect environment created in that culture disc so that the bacteria can grow. Your airway is creating that perfect environment by providing mucus for the bacteria to grow, right? And mucus is secreted by glands, submucosal glands. In pathology, you might have studied that increase in the goblet cell in the submucosal region increase the thickness of that submucosal region. And when you look at the ratio of whole thickness of the bronchi and the submucosal gland, you call it as Reed index, that is increased in COPD because of this goblet cell hyperplasia. So if it's a gland, basically goblet cells are part of the submucosal gland. So if I reduce the activity of the submucosal glands by using atropine like drugs, mucus production comes down, infection risk comes down, then exacerbations will also come down. So that added advantage LABA does not give me. LABA will only cause bronchodilation, but LAMA will give me that added advantage of indirectly reducing the exacerbations by reducing infections. So that's why LAMA is preferred. Okay. Now, apart from these inhaled medications, what else I can do for a COPD patient? What else I can do for the COPD patients? So there is a role of LVRS. So what LVRS stands for is lung volume reduction surgery. Lung volume reduction surgery. What do you mean by that? You have some part of the lung which is emphysematous, which is trapping more air and not letting you exhale that air out. What if I chop that part of the lung out, which is emphysematous? So then do I need to struggle to exhale that air? Do I need to purse the lips? Do I need to tripod position? No. If that emphysematous region is removed, then my symptoms will get better, right? So if you have emphysema not affecting the whole lung, but only in a selected region, that part of the lung can be removed. That is what we call as lung volume reduction surgery. So this procedure is suitable for localized emphysema, not generalized emphysema. So this procedure is suitable for emphysema affecting upper lobes. Smokers usually tend to develop upper lobe emphysema. Alpha-1 antitrypsin deficiency tend to develop lower lobe emphysema. So let us say that this is one lung and this part of the lung is having emphysema. This part of the lung is having emphysema. Then the surgeons will remove this part of the lung out. Only that part is removed, which is emphysematous. This procedure is what we call as lung volume reduction surgery. Okay, then there is a fourth thing, and that is called as LTOT. LTOT stands for long-term oxygen therapy. So just now when we were talking about the chronic bronchitis, I told you that they are called as blue bloaters. Blue because cyanosis. Hypoxia causes cyanosis. And bloaters because this hypoxia itself causes pulmonary vasoconstriction, that causes pulmonary hypertension, and right heart fails, what we call as cor pulmonale. So can I prevent it? Because once right heart fails, it becomes a reason for me to die. It's one of the cause for death. So can it be prevented? So if these pulmonary capillaries don't constrict, then pulmonary hypertension won't happen. Then right heart won't fail. I may not die. But why these pulmonary capillaries are constricting? Because of less oxygen coming to the alveoli. What if I make more oxygen to come to alveoli? Then pulmonary capillaries won't constrict. Pulmonary hypertension won't evolve. Right heart won't fail. The chance of my death comes down. Right? So in those chronic bronchitis patients who are having hypoxia, less oxygen entering the alveoli, they can benefit by giving them oxygen. This procedure is called as long-term oxygen therapy. Why long-term? Because the benefits are only there till I am getting oxygen. I stop giving oxygen, oxygen entering the alveoli comes down, pulmonary capillaries constrict, pulmonary arterial hypertension happens, and I will end up developing right heart failure. So it is indicated for patients with SpO2 less than 88%. SpO2 less than 88%. So the LTOT can be done for all patients. The lung volume reduction surgery is not generally done for the lower lobe predominant emphysema like in alpha-1 antitrypsin deficiency because it is technically challenging. It is easy to remove the upper lobe, but when you remove the lower lobe, it has a lot of technical challenges because once you remove the lower lobe, to hold it in place, there is no structure beneath it. So the whole lung has to descend down to settle on the diaphragm. So when the lung descends down, the trachea and all its attachments will disturb the mediastinum more. So it is technically challenging. That's why it is not performed. If I remove the upper lobe, it doesn't create any burden on the mediastinum. So that's why it is as of now restricted to upper lobe. Maybe with the advancement of technology in the future, we might do it for lower lobe, but for now it is only upper lobe. Okay. One extra point that you need to write for the long-term oxygen therapy is indication less than 88% saturation. There are more finer indications not required in a written exam, just mention less than 88%. And it is the only treatment that decreases COPD mortality. Means your LAMA, LABA, vaccinations, they make the patient's life better. Exacerbation comes down, symptoms improve, they become a little more comfortable, but it does not reduce the risk of death. The death can happen because of cor pulmonale, and this is the only treatment that prevents it. By giving oxygen, the chance of right heart failure comes down, so the chance of death comes down, right? So these are the key points you need to write in the management of COPD. So that completed our discussion on the COPD as well. As long as you are able to cover these points, specifically elaborating on emphysema versus chronic bronchitis, mentioning the drugs and treatments available for the COPD. I will also mention some newer drugs that I want you to know. And if you brief on the management, it's good enough for us, right? So in the newer drugs, I want you to mention a drug called roflumilast. It's not very new, which is a phosphodiesterase 4 inhibitor used in refractory cases. Refractory means those who are not responding to inhaled medications. You can put them on roflumilast, which is a phosphodiesterase 4 inhibitor, which will help you achieve some degree of bronchodilation. That's about the COPD. Now let me take you to the next question. Crazy loser, I lost your question. Can you just write the question? Okay, Sahaj Prajapati, we will be covering all the major questions in the Farre series for all the major systems of medicine. Similarly, my other colleagues will be covering the major questions that can be asked from their subjects. Apart from that, on the MedEd app, you have a Farre section where other questions are also covered, because we will not be able to cover all the possible questions in the videos itself. So I would suggest, if you have already completed some system, then stick to your source. From whichever source you studied, just revise that. But any system that you have not completed, watch the Farre video on the YouTube. And for the remaining questions, just refer to the MedEd app. Okay, so now let's go to the next question that can be asked from the topic. It is going to be on ILD, interstitial lung diseases, right? So what is the interstitium? Just for the conceptual understanding, interstitium refers to, acini, right? What are acini? The last part of the airway that includes respiratory bronchiole, alveolar ducts, and alveoli. That is where the gas exchange happens. The remaining part is called conducting airway. The trachea, bronchi, up to terminal bronchiole is called as conducting airway. There is no gas exchange. Gas exchange happens only in the acini. And these acini are held together by surrounding connective tissue. So acini and connective tissue put together, we call it as interstitium. And any disease that affects this interstitium, that means acini and connective tissue, can be called as interstitial lung disorders. Interstitial lung disorders. So in the introduction to interstitial lung disorders, you can write these are chronic. So there are some acute variants of ILD. For the simplicity, we will keep it as mainly it is about chronic. Chronic, diffuse, parenchymal, lung disorders. Means diseases which are chronic. They are not selectively affecting only one lobe. They are not selectively affecting only one lung or only one lobe. They are affecting both the lungs. And they are parenchymal disorders, means interstitial disorders affecting acini and connective tissue. Then we will call it as ILDs. And ILDs come under, these are restrictive lung disorders. Asthma and COPD were obstructive. So there was obstruction for the airflow. Here, nothing is obstructing, but there is a restriction to the expansion of the lung because the connective tissue or acini are damaged and they are not expanding well. So we will have restrictive lung disorders. So the restrictive lung disorders are characterized by FEV1 by FVC ratio of more than 0.7. In case of the obstructive, it was less than 0.7. So always remember, if it is restrictive disorder, FEV1 by FVC ratio will be more than 0.7. We will begin by understanding the classification of ILDs, because ILD is not a one entity. It's a group of disorders which are chronic, which are diffuse, means not selectively affecting only one lung, affecting both the lungs, and they are affecting the acini and connective tissue. Any disease which is chronic, affecting both the lungs and affecting acini and connective tissue, we are calling it as interstitial lung diseases. A classical example is asbestosis, coal workers pneumoconiosis. They are chronic, they are affecting acini and connective tissue, and they are not selectively affecting only one. Like, okay, asbestosis never said that I will only target right lung, I will only target left lung. It will affect both the lungs. So they are diffuse, chronic, and they are affecting the parenchyma, that is acini and connective tissue. So that's a classical example for an ILD. So all your occupational lung disorders, coal workers pneumoconiosis, silicosis, asbestosis, chronic berylliosis, they are all ILDs. So ILDs is a group of disorders and we will have a classification. There are various ways of classifying. The one that is there in the current edition of Harrison is what I'm going to put down here. But if you have alternate classifications from your pathology, you can write it down, because there is no one uniform standard classification followed in textbooks. So you can follow whichever you remember. Okay. So I'm just putting down the classification that is there in your Farre notes so that we are aligned on this. So we can classify the ILD into ILDs of known cause, where we know a cause. And then we will have idiopathic interstitial pneumonias, granulomatous disease, and some unique entities. This is the current classification that is there in latest editions. ILDs of known cause includes connective tissue disorders. What connective tissue disorders you are supposed to write in examples? I want you to write about rheumatoid arthritis and SLE. They are known to cause ILD, where we know the cause. RA is responsible or SLE is responsible. Then drugs are known to cause ILD. So if drug is induced, it's a ILD of known cause. Examples of drugs I want you to write are mainly two drugs, remember. The first thing is methotrexate. And the second drug I want you to remember is amiodarone. Amiodarone is known to cause interstitial lung disease, also fibrosis of the peritoneum, retroperitoneal fibrosis and the lung fibrosis. Okay. Then the idiopathic interstitial pneumonias, where we don't know the cause. As the name says, idiopathic, ILD is of unknown cause. Within that, I want you to write mainly two things. Rest of the things, if you can remember, fine, otherwise ignore it. So within that, we have idiopathic pulmonary fibrosis, usually abbreviated as IPF. The second one is non-specific interstitial pneumonia. Okay, the remaining ones, if you remember, write it, otherwise leave it. The next category is granulomatous diseases, where mainly you have to write about sarcoidosis. Okay, so as long as you are able to replicate this much classification, it is enough. So I will give you a flowchart to write. So if you have ILDs, the first thing is you can classify them as ILDs of known cause. Second one is ILDs of unknown cause, interstitial lung diseases where the cause is not known. And then granulomatous ILDs, where you have a granulomatous inflammation. So among the ILDs of known cause, the first thing you should mention is connective tissue disorder related ILDs. That is, first you can mention the example of rheumatoid arthritis and SLE. Second, occupational lung disorders, where we know the occupational exposure to something is responsible for the ILD, occupational lung disorders. And here you can mention the example of asbestosis, silicosis, and coal workers pneumoconiosis. Then in the granulomatous, just mention sarcoidosis. And for the ILDs of unknown cause, I want you to mention two of them. The first one is idiopathic pulmonary fibrosis, and the second one is idiopathic non-specific interstitial pneumonia. These are the two things. Apart from that, you have respiratory bronchiolitis, ILD, these commutative interstitial pneumonia, all these so-called smoking related ILDs. If you can remember from the table, you can mention. Otherwise, at least this much is required whenever there is a question on classification of ILDs. Okay, so all of them share common characteristics. What are those? These are chronic disorders. These are affecting the interstitium, that is acini and connective tissue, or what you call as parenchyma, and these are diffuse. None of them are selectively targeting only one lung. If there is asbestosis, both the lungs will be affected. If you have idiopathic pulmonary fibrosis, both the lungs will be affected. If you have sarcoidosis, both the lungs will be affected. If you have silicosis, both the lungs will be affected. Diffuse, chronic, parenchymal disorders, and all of them are restrictive disorders. The lungs getting fibrosed, so they are not able to inflate well to accommodate the air, so they are causing restriction to the air movement. There is no obstruction involved here. So now if I have to mention their clinical features, what are the common clinical features of all these ILDs shared together? We will discuss two of them individually, but shared together what clinical features we are expecting. Just like any other respiratory disorders, they will have cough, they will have shortness of breath. Cough and shortness of breath. But on examination, just give me 1 second. So on examination in interstitial lung diseases, say in COPD and asthma, you get wheeze because the airway is narrowed. When air passes through the narrow airway, it makes a whistling like noise musical noise. That's what we call as wheeze. Here we hear crackles. We will get something called as fine crackles, or crackles are also called as crepitations. Fine crackles or crepitations, a crackling sound. You can take a Velcro and try to open it. It makes a crackling noise. A similar noise is heard from the patient's chest, right? This is what is expected. If you want, you can write, they are also called as Velcro crackles. Though traditionally the word Velcro crackles is reserved for the idiopathic pulmonary fibrosis type of ILD. For a brief answer, you can write Velcro crackles. This is what we get on examination. And when it comes to diagnosis, the investigations, if you do PFT, what are we going to get? On the PFT, we get classical restrictive pattern. Restrictive pattern, that is, you will have decrease in FEV1, you will have decrease in FVC, but the ratio, because both of them are proportionately decreased, the ratio is not affected. It comes out normal, which is more than 0.7. The lung is restricting, so less air gets into the lungs, less air goes out. So the FEV1 and FVC are proportionately reduced, and that's why ratio comes out as more than 0.7. This is classical restrictive pattern. But PFT is not the investigation of choice for the diagnosis of ILDs. So remember one simple thing. If it is an obstructive disorder, PFT is a diagnostic test because it clearly shows the ratio less than 0.7, and you can also prove whether it is persistent or reversible obstruction by doing the bronchodilator reversibility test. But in the restrictive disorder, it only tells that it is a restrictive disorder. But pneumonia is also a restrictive disorder. Pleural effusion also is a restrictive disorder. Pneumothorax also restricts the lung expansion, so that's also a restrictive disorder. All of them are restrictive disorder. So how will you get to know that it is the lung where the problem? It's not in the pleura, not in the pleural cavity. We have to rely on imaging. So for all restrictive disorders, the investigation of choice will be imaging. Pneumonia, how do you diagnose? X-ray, imaging, right? Pleural effusion, how do you diagnose? Ultrasound, X-ray, CT scan, imaging. Pneumothorax, how do you diagnose? Ultrasound, CT scan, X-ray, imaging. So ILD also, the investigation of choice will be imaging. And X-ray is not enough. X-ray will show the interstitial involvement quite late, so we have to rely on the HRCT, right? And HRCT shows two patterns that you need to write. One is called as usual interstitial pneumonia pattern. Usual interstitial pneumonia pattern, or UIP pattern. The other finding you may get on the HRCT is called as the non-specific interstitial pneumonia pattern, or NSIP pattern. UIP pattern or NSIP pattern. So what do I get in the NSIP pattern? We will see fibrosis of the lung showing reticular opacities, and a classical finding called as ground glass opacities. Means opacities which are neither fully opaque nor fully translucent, somewhere in between. Such opacities are called as ground glass opacities. So this is the word that teachers are looking for when you write about NSIP pattern. They want you to mention ground glass opacities, or GGOs. In case of usual interstitial pneumonia, here also you will have reticular opacities. Reticular means thread-like. So you have some opacities running like threads. Reticular opacities. And you will have traction bronchiectasis. Means when the lung is getting fibrosed, it pulls the bronchi in different directions, and because of that the bronchi become dilated, and that dilated bronchi is what we call as traction bronchiectasis. And when there are too many bronchi dilated, the whole lung, like if this is what I am looking at, this is one lung we are looking at, and many bronchi are dilated, this whole lung now starts appearing like a honeycomb. So that is what we call as honeycomb appearance. Your examiners are looking for this word, honeycomb appearance. Honeycomb appearance. So as long as they see these two words, they will move forward. Okay, that means the guy knows about UIP pattern and NSIP pattern. Let me move forward. Now, which ILDs present with this NSIP pattern. Usually, the non-specific interstitial pneumonia and connective tissue disorder related ILDs, sarcoidosis, they present with the NSIP pattern on HRCT. And idiopathic pulmonary fibrosis presents as the UIP pattern on the HRCT. So if it is honeycomb changes that you see on the HRCT, it is pointing towards interstitial, the idiopathic pulmonary fibrosis. But if you see ground glass opacities, it is pointing towards NSIP or SLE or rheumatoid arthritis related or sarcoidosis related ILDs. Okay, so this is the basics about ILDs: the classification, symptoms, basic investigation, including the HRCT. Now, when it comes to management, we have to dig into the individual types. So we will discuss two individual types. The first one is idiopathic pulmonary fibrosis or IPF. Idiopathic pulmonary fibrosis or IPF. This is the first thing that you should write is this is the most common of all ILDs that we know, much more common than even RA or SLE associated ILD. RA patients or SLE patients don't develop the ILD so often. So overall, this is the most common ILD. Idiopathic pulmonary fibrosis is the most common interstitial lung disease. And as the name says, idiopathic, so of course I don't know the exact cause. We are only aware of risk factors. So then comes the question, what are the risk factors for someone developing idiopathic pulmonary fibrosis? Pay attention, I'm going to make it easier for you to recreate this answer in the prof exam. The risk factors are, we are cursed. The being male is cursed. So males are at increased risk. Age more than 55 years increases the risk, and smoking increases the risk. Apart from that, yes, genetics. Okay, remember these risk factors. And in terms of clinical features, just like any other ILDs, these patients present with cough and shortness of breath. And on examination, as usual, as I've already told you, we get classical fine crackles called as Velcro crackles. Velcro crackles. This word generally impresses the examiner, so make sure you write Velcro crackles. And when it comes to the management of these patients, of idiopathic pulmonary fibrosis patients, I have to also talk to you about diagnosis. Diagnosis is simple. As I've already told you, the PFT will show restrictive pattern, and you know what is restrictive pattern. Restrictive pattern means you will have decrease in FEV1 and FVC, but the ratio is 0.7 or higher. You will get restrictive pattern. And on HRCT, what are we going to get? This is an ILD which presents with the usual interstitial pneumonia pattern on the HRCT. That means you will have plenty of traction bronchiectasis giving rise to honeycomb-like appearance. So when it comes to management, these patients carry poor prognosis. So being male, having this disease, you have a very high risk of death because of hypoxia. Lungs are restricting improper oxygenation, hypoxia, you can die. Second, you can also develop right heart failure, cor pulmonale, and die. So when it comes to management, we use drugs which slow down the fibrosis. We call them as anti-fibrotic agents. And there are plenty new drugs, but the important ones that are being used from long time are mainly two. One is called as pirfenidone, and the second one is nintedanib. Both these drugs decrease the activity of fibroblasts, and fibroblasts are the ones which are responsible for causing the lung fibrosis. So by decreasing their activity, I can reduce the progression of lung fibrosis. That is one. Second, if they don't help, we can go for immunosuppressants. Immunosuppressants will not only suppress the immune cell activity, but also the fibroblast activity. And in worst case scenario, if that is also not helping, then we have to go for lung transplantation. This is about idiopathic pulmonary fibrosis. Key point to remember is it has UIP pattern, and it is typically more common in elderly males who have history of smoking. Please remember this point, because exactly opposite of it is what I want you to write when it comes to NSIP. So the second ILD that you need to write about is non-specific interstitial pneumonia, or NSIP. Non-specific interstitial pneumonia, or NSIP. This is also idiopathic, ILD of unknown cause. And when it comes to this, if you have to talk about risk factors, write exactly opposite of IPF. IPF was more common in males. This is more common in females. IPF was more common in elderly, age more than 55 years. This is more common in young, age less than 40 years. Age less than 40 years. IPF was more common in smokers. This is more common in non-smokers. So a typical NSIP patient is a young female who does not smoke. So if you fall in this category, you are at risk of developing non-specific interstitial pneumonia. Young female who does not smoke. Now just don't use this as an excuse to start smoking, saying that, sir, this is my New Year resolution. In 2026, I want to eliminate the risk of developing NSIP because I fall in this category. Well, there are some diseases which are better treated than prevented. Means if you try to prevent the NSIP, I don't know if it is going to come to you or not, but if you want to prevent, you may end up preventing by smoking, but you will definitely push yourself towards COPD and lung cancer risk, right? So in terms of clinical features, these patients also present with same standard symptom, that is cough and shortness of breath. On examination, here also you will get crackles. And for a diagnosis, if you have to go with PFT, as usual, it will show restrictive pattern. But if you go for HRCT, it will show the pattern called as NSIP pattern. And NSIP pattern means you will see ground glass opacities. You will see ground glass opacities. Okay, that's Ayush koshish karta hu. We will call it as ground glass opacities. Now, when it comes to its management, unlike the IPF is a very nasty, very bad disease. Most of the people will die because of the disease. But NSIP, most of the patients, in fact, almost close to all of them, make a good recovery with a very short course of steroids. I don't even need to use immunosuppressants. Simple steroids for a short period of time is enough for most of the patients. So when it comes to management of NSIP, I want you to write the steroids or corticosteroids. Only few patients may require immunosuppressants. And generally, we don't have to go for lung transplantation in these patients. We don't generally get into that situation, right? So from this, we learn that the prognosis of NSIP is better than the prognosis of IPF. So you can close your ILD discussion by writing this one note. The NSIP carries better prognosis than idiopathic pulmonary fibrosis. So with that, your ILD answer is complete. So what is expected by the examiners? They want you to write a classification, a basic introduction where you use these terms: chronic, diffuse, and parenchymal. These three terms they are looking for. Second, in the introduction, make sure that you mention ILD is a restrictive disorder, unlike COPD and asthma, which are obstructive disorder. Classification, either copy this table. If not feasible, just keep this classification simple: known cause, unknown cause, and granulomatous. Sorted. Known, it's pretty logical: SLE, rheumatoid arthritis, that is connective tissue disorder, and occupational lung disorders. Granulomatous sarcoidosis, you know, it is classically non-caseating granulomas that you get. And unknown, the two that we discussed, IPF and NSIP, right? After that, you can replicate the same symptoms for all respiratory disorders: cough and shortness of breath. Only auscultation findings will change. COPD and asthma, you had wheeze. Here you will have crackles. PFT, you know, restrictive pattern, because this is a restrictive disorder, so write that. Only thing you want to elaborate is the HRCT findings, the UIP pattern for IPF and NSIP pattern for NSIP and other ILDs. Okay, NSIP means ground glass opacities, UIP means honeycomb changes. These is the key points that you need to remember. IPF, elderly male smoker. Management: Antifibrotic agents, immunosuppressants, lung transplantation. Remember the name of these two drugs, pirfenidone and nintedanib. Those are antifibrotic agents. NSIP, think opposite of UIP, IPF. That was elderly male smoker, young female non-smoker, NSIP. HRCT, NSIP pattern, that is ground glass opacities. It is not very aggressive, so steroids and immunosuppressants do the job most cases. You don't have to write about the lung transplantation. Karthik, there may be variations from university to university about the colors. So just talk to the assessor available in your examination hall. If allowed, preferably use colored pencil because it appears pleasing, and not just pleasing, but see, whenever we represent data in colors, it is impressive. Examiners will pay attention to the details of the information you have put. The answer appears rich and you will end up getting half to 1 mark extra. And if you write the same content in monochrome color, just black or blue, you may end up getting half mark less. It's basic human psychology. But make sure you talk to the invigilator in the examination hall, whether in that particular university colored pens or pencils are allowed or not. So the ground glass opacities are opacities. See, basically ground glass refers to a form of glass which is semi-transparent. Means if there is a ground glass, if I hold something on the other side, you feel that there is something. It is visible that there is something, but what is it exactly? Whether I'm holding a pencil or a candle, that much detail is not visible. It is a semi-translucent glass. Such glasses are called as ground glasses. So similarly, if I get an opacity on the HRCT which is not fully opaque, it's like opaque means fully white. Neither it is fully dark, somewhere in between. Such opacities are called as ground glass opacities. Okay, so that is about the ILD. So we will take one more question. We'll take just 10 more minutes, and that is going to be pulmonary hypertension. Apart from that, you may expect a question on pulmonary embolism, sarcoidosis, bronchiectasis, occupational lung disorders, pneumothorax, and pneumonia. In your written paper, most likely they may ask about sarcoidosis, bronchiectasis, or occupational lung disorders. The pneumothorax or pneumonia may come in your ward discussions because your respiratory cases will be either about the pleural effusion or pneumonia or COPD. These are your standard bedside cases. So please make sure that you also read about these questions from the Farre notes available on the MedEd app. With that, your respiratory system will be complete. Now, remaining 10 minutes, let me address another important question, which is pulmonary hypertension. Okay. So if they're asking a question on pulmonary hypertension, the question may go like this: define pulmonary hypertension, discuss diagnostic evaluation and its management, right? So we'll begin with an introduction. Can anybody tell me what is pulmonary hypertension and how is it different from the systemic hypertension? So remember that we have a right side of the heart which primarily is concerned with bringing the deoxygenated blood from the body to the lungs so that it gets oxygenated, and once it is oxygenated in the lungs, it will go to the left side of the heart, and pulmonary artery is the one that is bringing the blood from the right side of the heart to the lungs. So this is what we call as pulmonary artery. So elevation in the pressure in the pulmonary artery is what we call as pulmonary hypertension. Elevation in the systemic blood vessel, that is aorta and its branches that bring the blood to different body parts, if there is elevation in their pressure, it is called as systemic hypertension, right? So pulmonary hypertension refers to elevated pulmonary artery pressure. So just for the conceptual understanding, this is my right atrium. Right atrium receives the blood from superior vena cava from the upper part of the body and inferior vena cava from the lower part of the body. And once the blood comes to this right side of the heart, from right atrium it goes to the right ventricle. From the right ventricle it gets ejected to pulmonary artery. Pulmonary artery divides into two trunks, one going to the right lung, another going to the left lung. And then once it goes to the lung, it goes through multiple divisions inside the lung. There will be multiple divisions, and those divisions will divide further till it becomes what we call as a pulmonary capillary. It becomes a pulmonary capillary. and a pulmonary capillary is lining an alveolus. So once the air comes into the alveoli, that oxygen will now get its way into the pulmonary capillaries, and from the pulmonary capillaries the oxygenated blood will go to the left side of the heart through what we call as pulmonary veins. So if there is increase in the pressure in this pulmonary artery, then we will call it as pulmonary hypertension. So if the pulmonary artery pressure is increased, this area pressure is high, we will call it as pulmonary hypertension. Elevated pulmonary artery pressure, that is a basic introduction. But of course I need to have objective numbers, right? Systemic hypertension when BP is more than 130/80. Currently, according to the latest guidelines, when it is more than 130/80 systemic BP that you check regularly, then we will call it as hypertension, right? Similarly, for the pulmonary hypertension, we don't have two separate numbers, systolic and diastolic. We will take a mean pressure. Systolic and diastolic, we take the mean pressure. And whenever the mean pulmonary artery pressure is more than or equal to 20 millimeters of mercury, means when we measure the mean pressure of this pulmonary artery, if it is more than or equal to 20 millimeters of mercury, then it is pulmonary hypertension. If it is less than 20 millimeters of mercury, like let us say 17, 16, then there is no pulmonary hypertension, right? So objectively, teachers expect you to mention the number. The number is more than or equal to 20 millimeters of mercury. Now, why the pressure in this pulmonary artery will increase? A couple of minutes back, we learned one example. What was the example? Chronic bronchitis. So in chronic bronchitis, what happened? Amount of oxygen entering the alveoli reduced. So because of that, this pulmonary capillary got constricted. Because of its constriction, pressure in the pulmonary capillary was high, and as we learned that the fluid moves from high pressure to low pressure zone. So already pulmonary capillary pressure is high. So for the blood to come into this, the pressure in the pulmonary artery has to increase. Then only blood will come from the pulmonary artery to capillaries. So by default, the pressure starts increasing in the pulmonary artery. When it is increased, we are going to call it as pulmonary hypertension. And because of that, eventually right ventricular pressure, right atrial pressure will increase, inferior vena cava pressure will increase. Because of inferior vena cava pressure going high, we will develop edema. That is our cor pulmonale, right? That's why we said that COPD can lead to right heart failure. We call it as cor pulmonale. And by giving oxygen, that is what we call as long-term oxygen therapy in COPD. By giving oxygen, I'm minimizing these complications. So if oxygen comes to the alveoli in higher concentration, this capillary won't constrict, pulmonary artery pressure won't rise, right heart won't fail. Okay, so this is basic understanding of pulmonary hypertension. Pulmonary hypertension refers to elevated pulmonary artery pressure. We express it in terms of mean more than or equal to 20 millimeters of mercury is equal to pulmonary hypertension. Now, what can cause it? The causes for pulmonary hypertension. So the first, which is the most common cause for pulmonary hypertension, is left heart disease. Now during your ward discussions, your teachers might have told a statement that most common cause for right heart failure is left heart failure. Most common cause for right heart disease is left heart disease. I'll tell you why today. So from the pulmonary veins, you know that blood once gets oxygenated, it drains to the left atrium. And from the left atrium, the blood gets into left ventricle. And from the left ventricle, you know that you eject the blood to aorta for it to go to tissues. So oxygenated blood goes to the tissues from the aorta. Once it is delivered, the oxygen comes back to the right side of the heart to get oxygenated again. This is the basic circulation. Now just take an example. Let us say I had a mitral stenosis. This opening is narrow. It's not easy for me to transfer the blood from left atrium to left ventricle. So pressure inside of the left atrium will start rising. Like if the opening of this bottle is narrow, when I try to squeeze the fluid out, pressure inside builds more. So pressure in the left atrium will increase. Now, if the blood has to move from pulmonary vein to left atrium, pulmonary vein pressure has to be higher than left atrium. So by default, if left atrial pressure increased, pulmonary vein pressure will also increase. Now, if the blood has to move from capillaries to pulmonary vein, the capillary pressure has to be higher. So if left atrial increased, pulmonary vein had to increase. If pulmonary vein increased, pulmonary capillary pressure also has to increase. If pulmonary capillary pressure is high, pulmonary artery pressure has to be higher than that. So chain of events lead to pressure build up everywhere, reaching all the way to the right side of the heart, eventually superior vena cava, inferior vena cava. So the problem that started in the left reached the right side of the heart, and on the way it also reached the pulmonary artery where pressure increased, and that is what we call as pulmonary hypertension. So left heart disease like mitral stenosis, mitral regurgitation, aortic stenosis, left heart failure, these are much more common causes for pulmonary hypertension. Okay, so left heart disease, we can mention few examples like mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and left ventricular failure. Collectively, these are much more common causes for pulmonary hypertension and left heart failure. The second most common cause for pulmonary hypertension is chronic lung disorders. And when lung disorders cause pulmonary hypertension, that is what we call as cor pulmonale. We call it as cor pulmonale. So this can happen because of COPD, which is the most common cause for cor pulmonale, and some ILDs. Because in ILDs also amount of oxygen entering the alveoli is reduced. In chronic bronchitis type of COPD, again oxygen entering the alveoli is reduced. Pulmonary capillaries constrict, behind that pressure increases. So these are the second most common cause. Left heart disease is the most common cause. Lung disease is the second most common cause. And then the third cause for pulmonary hypertension, we will name it little differently. Pulmonary hypertension means pulmonary artery pressure high, but here I am going to call it as pulmonary arterial hypertension. Pulmonary arterial hypertension, or PAH. PAH refers to pulmonary hypertension without lung disease and without heart disease. You have pulmonary artery pressure high, but you don't have any problem in the left heart. You don't have any problem in the lungs, but still pulmonary artery pressure is high. This is comparable to what you call as secondary hypertension. Now, when you study about systemic hypertension, you have essential hypertension and secondary hypertension. Secondary means you have an identifiable treatable cause. Like you have pheochromocytoma, Cushing syndrome, renal artery stenosis, you have a cause. But most patients of systemic hypertension, they don't have an identifiable cause. So we call all of them as essential hypertension or idiopathic hypertension. So if I have a similar phenomenon occurring in the pulmonary artery, means I don't have an identifiable cause, but I still have elevated pulmonary artery pressure, then we will call it as pulmonary arterial hypertension. Means the only thing I can blame here is artery. Heart can't be blamed, lung can't be blamed, only artery can be blamed. That's why we're calling it as pulmonary arterial hypertension. Means you are at fault. Heart is not at fault. Lung is not at fault. Only artery is at fault. Then we will call it as pulmonary arterial hypertension. So pulmonary arterial hypertension refers to pulmonary hypertension in the absence of left heart and lung diseases. Left heart and lung diseases. So you don't have COPD, you don't have mitral stenosis or any of those problems, but you still have pulmonary arterial hypertension. Then we call it as pulmonary arterial hypertension. This pulmonary arterial hypertension is more common in females, and it is associated with scleroderma. It is more common in patients with scleroderma, and anyway you know that scleroderma is more common in females. Okay, so these are the causes for pulmonary hypertension. Now if I have pulmonary hypertension, the next question is, how do I diagnose it? Let me also tell you about clinical features before I talk about the diagnosis. How will I get to know that someone has got pulmonary hypertension? Number one, because of this pulmonary hypertension, they may have right heart failure. And once there is right heart failure, you will have raised JVP, ascites, and pedal edema. Second, pulmonary hypertension often has loud P2 on auscultation. P2 becomes loud because the pulmonary artery pressure is high. And third, you may have, because see, if the pressure in the pulmonary artery is high, for me to eject the blood into this pulmonary artery as a right ventricle, I need to put more effort, because as I've already told you, fluid moves from high pressure to low pressure zone. So if pulmonary artery pressure is high, right ventricular pressure has to increase over and above the pulmonary artery pressure, then only blood will be ejected into it. So right ventricle has to generate more pressure. To generate more pressure, it has to contract more. If it contracts more, it is doing more work. If it does more work, it develops hypertrophy, right? So you will end up developing right ventricular hypertrophy. And a hypertrophic ventricle, when it contracts forcefully, right, it may lift the sternum while contraction, and that lift may be visible to us. So we'll call it as right parasternal lift or heave. Normally right ventricle's contraction is not visible because it's just contracting minimally, it's not disturbing the sternum. But if it is muscular and forcefully contracting, it will be lifting the sternum. We will call it as right parasternal heave. These are the findings you can get once you have suspected the presence of pulmonary hypertension. For the diagnosis, the investigation of choice is going to be right heart catheterization. Because see, if I have systemic hypertension, I can tie a cuff, inflate it, and at whatever inflated pressure the artery is no longer felt, that is the pressure in that artery, right? That's the systolic BP. But can I tie a cuff to the pulmonary artery and measure it? Not possible. So how will I diagnose? Pulmonary hypertension is diagnosed by right heart catheterization. So what do I do? Through the internal jugular vein, I will pass the superior vena cava, get into the right atrium. I will pass a wire or a catheter into the right ventricle, and then I will take it to the pulmonary artery. And I will measure the pressure in the pulmonary artery directly. This procedure where I am putting a catheter into the right side of the heart, we will call it as right heart catheterization. So right heart catheterization is the investigation of choice. Right heart catheterization is the investigation of choice. And once we do right heart catheterization, if the mean pulmonary artery pressure is more than or equal to 20 millimeters of mercury, then you know it is suggestive of pulmonary hypertension. If it is less than that, then it is not pulmonary hypertension. There may be other causes for the patient's symptoms. Investigate accordingly. Okay. Once you're diagnosed, right, then comes the management. We will keep the management little simple. When we are talking about the management of pulmonary hypertension, first thing is we learned about three major causes. Left heart disease as the most common, lung disease as the second most common, and relatively less common is pulmonary arterial hypertension, where neither left heart nor lung has a problem. Now, if heart has a problem, what is the best treatment? Treat the problem. If mitral valve opening is narrow, because of that the pressure is building everywhere, make the opening wide, right? Replace the valve or dilate the valve so that the pressure in the left atrium decreases, pulmonary vein pressure decreases, capillary pressure decreases, pulmonary artery pressure also decreases. Simple. If less oxygen entry into the lungs in COPD is causing pulmonary vasoconstriction, make more oxygen to get into the alveoli. That's why we are doing LTOT, long-term oxygen therapy. Then the pulmonary artery pressure will come down. So in simple words, you can say if there is a treatable underlying cause, treat it. Only thing is pulmonary arterial hypertension, where we don't have an identifiable underlying cause, there we need to do something for the patient, right? So in the management, right, pulmonary hypertension due to left heart disease and COPD, their management is treat underlying cause. But if it is pulmonary arterial hypertension, Then we treat them with pulmonary vasodilators. Give the drugs that dilate the artery so that pressure comes down. So can anybody name some drugs that because Uthappa, to check the pressure in the pulmonary artery, it's not possible for us to check the pulmonary artery pressure directly, right? From outside we can't check. Echo can measure, but echo can only measure the systolic pressure. It can't measure the diastolic pressure. And for the diagnosis, I need the mean. So for mean, I need both systolic and diastolic. For systemic hypertension, we can check because we can tie a cuff to any of the superficial arteries. Pulmonary artery, how will I tie the cuff? I have to open the chest and then tie a cuff to pulmonary artery. Not possible, right? So simple thing is put a BP measuring wire or a catheter into the pulmonary artery and measure it directly there, and that will measure how much pressure is there in systole, diastole. It will give you the mean value and you have the diagnosis done. So pulmonary artery vasodilators can be used. See, again, Boyle's law, volume and pressure are inversely related. So if I dilate an artery, volume increased, pressure decreased. Simple. But how will I dilate this pulmonary artery? See, if I have systemic hypertension, like common BP, there also we use vasodilators like beta blockers, calcium channel blockers. They cause vasodilatation, right? So what drugs can cause vasodilatation of the pulmonary arteries? Yes, the calcium channel blockers can cause. So one class of drugs that we can use to treat pulmonary hypertension is calcium channel blockers. Example, amlodipine. Systemic hypertension refers to increase in the BP in your systemic blood vessels. Systemic blood vessel means aorta and its branches, means anything that is coming from the left side. If pressure in the aorta is high or its branches, subclavian, then the descending aorta, right, iliac vessels, femoral vessels, systemic vessels, which are carrying oxygenated blood. If the pressure in them is high, we call it a systemic hypertension. In the systemic hypertension, if I know a cause for this, then it is secondary hypertension. Okay, just to give you a pictorial idea. So we are